Hi, I'm Dr. Brian Kaufman, a retired family doctor, a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society, a 501c3 dedicated to the unmet needs of the CLL community. And today I'm going to be sharing with you the final 7-year follow-up and retreatment sub-study analysis of the huge game-changing MURANO trial. This is a venetoclax-rituximab combination for patients with relapsed refractory chronic lymphocytic leukemia. This research was presented by Dr. Arnon Kater of the Amsterdam University Medical Center, who led a group of international researchers. It was presented at the European Hematological Association's annual Congress in Frankfurt, Germany in 2023. So let's go to what the bottom line that this research showed. In this final long-term analysis of this groundbreaking MURANO trial, progression-free survival and overall survival benefits for venetoclax-rituximab over bendamustine and rituximab were sustained. There was no surprises. It continues to be the better therapy. Furthermore, achievement of undetectable measurable residual disease, or uMRD, was associated with prolonged progression-free survival. What was new here is the data that suggested that retreatment with venetoclax-rituximab after patients had progressed was a viable option. Let's look at the background here. The phase 3 MURANO trial had previously reported superior progression-free survival and overall survival with this fixed duration of venetoclax-rituximab versus bendamustine and rituximab in relapsed refractory patients. At the 5-year update, the median progression-free survival for VEN-R was 53.6 months versus 17 months for the bendamustine-based therapy. And the overall survival was 82% for those on venetoclax plus rituximab versus those on bendamustine and rituximab, where it was only 62%. This research represents the final 7-year update of that data. So what were the methods and participants? Let me review that with you. It's the final analysis, and it specifically updates the progression-free survival and overall survival. It looks at measurable residual disease in patients in the main study, as well as the retreated sub-study that I'll talk about. We talked about this trial before, but I'll remind you that patients with relapsed refractory CLL were randomized to receive either venetoclax-rituximab, so after the ramp-up, venetoclax 400 milligrams daily for 2 years, and monthly rituximab for the first 6 months, or bendamustine and rituximab, sometimes abbreviated to BR, for 6 months. In the sub-study analysis, which looks at the data from 2018 forward, patients whose disease progressed received VEN-R, venetoclax and rituximab, the same schedule that I just read above to you, as either retreatment, if they'd progressed after the venetoclax-rituximab, or as a crossover from the bendamustine and rituximab arm. Let's dig into the results. At the final data cut point, which was August the 3rd, 2022, venetoclax-rituximab treated patients, there was 194, had a median progression-free survival of 54.7 months versus only 17 months for the bendamustine and rituximab group. There was 195 patients in that group, so almost identical numbers. 7-year progression-free survival were 23% with venetoclax-rituximab, while no patients treated with bendamustine and rituximab were progression-free at that time. So everyone had progressed in that group, where almost a quarter of the patients with VEN-R had not progressed. 7-year overall survival was almost 70% for venetoclax-based therapy versus just a little over half with bendamustine-based therapy. Median time to next treatment was 63 months for the venetoclax-rituximab cohort versus 2 years for the bendamustine-rituximab cohort. 37% of the Ven-R patients have not received any subsequent anti-CLL therapies. Among the venetoclax-rituximab treated patients who had undetectable measurable residual disease, uMRD, at the end of treatment without any progression, median progression-free survival from end of treatment was 52.5 months versus 18 months for those who are MRD positive at the end of treatment. 14 or 16.9 patients had no progressive disease nor confirmed MRD conversion, in other words, going from negative MRD to MRD positive at the end of 7 years. In the 63 or 75.9 patients who had MRD conversions, median time to conversion was 19.4 months. So this is after they've stopped therapy. It took 19.4 months for them to go from MRD negative to positive. Among the 63 patients who converted, 39 eventually progressed or died, and the median time from conversion to progressive disease was 28 months. So there's a point that I want to stop there on, because what that's telling us is just because you've gone from MRD negative to MRD positive, you may have years before you need to start therapy again. In the sub-study analysis, and there was 34 patients who received venetoclax-rituximab retreatment, and this could be either after having received BR or Ven-R, 92% of those who had at least one high-risk feature, IGHV unmutated disease, genomic complexity, deletion 17p, or a TP53 mutation. So it was the high-risk group that tended to relapse and need retreatment. Despite this, 56% achieved uMRD at the end of treatment in the main study. Best overall response to retreatment was 72%, and mean progression-free survival was 23.3%. Median range of time from the last Ven dose in the main study to the Ven ramp-up in the sub-study was 2.3 years. 8 patients achieved uMRD at the time of retreatment, at the end of treatment. However, none of those patients maintained their uMRD status. So let me say that again. 32%, or 8 patients, achieved uMRD at some point, but no patient maintained that. There was no new safety data that were observed in this study. So what are our conclusions? In this final long-term analysis of the Murano study, progression-free survival and overall survival benefits for venetoclax-rituximab over bendamustine-rituximab were unsurprisingly solid and sustained. There is no longer any ethical reasons to do studies using bendamustine and rituximab when we have such strong data demonstrating the superiority of venetoclax and rituximab. Once again, we learned that the deeper the remission, the better prognosis. Reaching undetectable MRD, uMRD, was associated with prolonged progression-free survival. In the Ven-R treated patients in the subgroup, those who were retreated, that is, overall response rate was high and uMRD was still attainable but not maintained in this high-risk group. Overall, this data continues to support the idea of a fixed duration, in this case a 2-year therapy of venetoclax-rituximab and chronic lymphocytic leukemia, and suggests that retreatment with venetoclax-rituximab is a viable option for pretreated patients. Since the venetoclax-rituximab combo was the one that was studied in the relapsed refractory setting, this is the one that's approved in the relapsed refractory setting. Though I would like to point out that it's widely believed among many CLL experts that combining venetoclax with obinutuzumab, which is already proven to be a superior antibody to rituximab, would probably yield even better results. These results are very encouraging in some very difficult to treat patients, offering a powerful and durable therapy. But despite deep responses, we have to look at the reality that less than 17% of patients had no progression of their disease and maintained their undetectable MRD status at the end of 7 years. We are extremely grateful for this therapy that knocks back the disease for many years, but we are still looking for curative approaches. Thanks so much for listening. Stay strong. We are all in this together.